Well, welcome to today's PCR webinar, How Should I Manage Complex Anatomical Situations During My Tavi Procedures? I am Ole de Bakker from Rigshospitalet in Copenhagen, in Denmark, and it is with great pleasure to be joined today by Professor Mohamed Abdelwahab from the Heart Center in Leipzig in Germany and by Dr. Didier Tchétché from Clinique Pasteur in Toulouse in France. So during today's session, our intention is to review some complex anatomical Tavi cases and scenarios. Dr. Tchétché will start by deep diving into the complexities of Tavi in bicuspid aortic valve stenosis. Dr. Abdelwahab will discuss the complexities that can be associated with valve-in-valve Tavi, and this with particular focus on coronary protection. And finally, I will touch upon current trends in Tavi when dealing with challenging transfemoral access, including a step-by-step description on how to perform safely and successfully percutaneous transaxillary Tavi. If any questions, please do not hesitate to post your questions in the chat box. And I would say, let's bring up the slides, and Didier, the floor is yours.
Okay, thank you, Ole. So what I will try to do during the next 12 to 15 minutes is to try to drive you through the main elements to safely treat patients with a bicuspid aortic valve anatomy. So here are my conflicts of interest. So the first thing that we need to understand is that all the patients that have been treated and reported in the literature are overall selected bicuspid aortic valve patients, because we all know that there are differences in terms of anatomical features of bicuspid aortic valves as compared to tricuspid valves with larger annuli. Circularity is the same, but larger annuli, dilation of descending aorta, and more importantly, an extensive calcium pattern. So this has been explored quite extensively by the team, the collaborative work led by the team in Los Angeles. And what we can clearly see is that depending on the phenotype of bicuspid, but more importantly on the association of raphe and extensive calcification, we may have some adverse impact on the survival of the patient. So if you have a raphe that is calcified in excess of calcification, this may hamper survival of the patients. As you can see, close to 2 years follow-up. So it's not a benign thing. Selected patients, let's keep an eye on the presence of the raphe and the extent of calcification, apart from potential coronary artery disease, aneurysm, and so on. These are the key elements for selecting the appropriate patients for Tavi in bicuspid aortic valves. So the patient we're going to discuss today, 81 years old male with a standard history favoring a Tavi as compared to a surgical aortic valve replacement. And as we do for every aortic stenosis, we obtain a CT scan, and as you can clearly identify for this patient, this is quite a complex patient because we have a type 1 left-right bicuspid aortic valve phenotype with a raphe that is calcified and quite extensive calcification at the tip of the leaflets associated with that raphe. So not the most complex bicuspid phenotype and calcification pattern, but this is already quite a complex anatomy. So after that issue of selection comes the issue of sizing for bicuspid aortic valves. And sizing is really the core of the thinking process when it comes to planning the procedure, making sure that we're going to be able to select the appropriate device, the appropriate size of device, and the appropriate technique for a particular patient. Every single bicuspid aortic valve is a different patient, so we need to really tailor the device and the treatment to our patient. So as you can see, CT scan and MSCT is really the gold standard, as it is the case even for tricuspid aortic valves. Apart from selecting the patient, it is the gold standard to size the patient. And we have gathered a lot of experience, I would say, throughout the last 5 to 10 years in the understanding of the way to size bicuspid aortic valves, slightly different as compared to tricuspid aortic valves. So we may size on the left part of the slide only on the annular dimensions, but we also can size middle part of the slides to pictures in the middle on the supraannular measurements, whether it be a commissural to commissural distance or a supraannular tracing. And we're going to see how we can integrate that. And at last, a more recent way to size for bicuspid aortic valves is to use the circle method. The circle method is more relevant for balloon expandable platforms. And the idea is only to put a circle of 23, 26, 29, whatever size you think is suitable for your patient in the anatomy, in the sinus of Valsalva, to try to understand what is the risk of sinus sequestration, what is the risk of annular rupture, what is the risk of damaging the overall aortic root with a balloon expandable platform. So the first 3 methods apply for all kinds of devices. The circle method is really dedicated for balloon expandable platforms. So the CT scroll technique is really something that we need to master when we are thinking about sizing for bicuspid aortic valves. So briefly, the principle is to scroll from the aortic annulus plane to upward the supraannular region, just to try to understand what is the phenotype of bicuspid, what is the distribution of the leaflet and the calcium, the coronary height, the dimensions of the SOV, STJ, the ascending aorta, all the metrics that are required to select our patient and to size. And what we are going to do, and what was done in the Bavard registry, was to match the aortic annulus diameter, whether it be the mean perimeter derived diameter or the area derived diameter. It doesn't really matter. Most of the time in bicuspid aortic valves, the circularity is quite acceptable. So both metrics are going to be close to each other. And then you're going to confront that to the commissural to commissural distance, 4 millimeters above the annulus. And you're going to obtain something like that with 3 different type of landing zone configurations. In the tricuspid anatomy, the landing zone starts from the annulus and then goes downwards towards the LVOT. For bicuspid aortic valves, it's the opposite. You start with the annulus and then you scroll upwards, because this is where the device is really going to anchor. What we saw in the Bavard registry, in 10 to 15% of the cases, if you relate the final diameter, mean perimeter derived diameter of the device to the annular dimension at baseline, it's going to be 10 to 15% smaller than what you measured at the annular plane. So really the sealing in bicuspid aortic valve is obtained upwards. So that's why that landing zone configuration has to be understood. It could be tubular, annular perimeter derived diameter matches the commissural to commissural distance, more or less 10%. You're going to size based on the minimal dimension, which is going to be the annulus. Flared configuration, with a commissural to commissural distance greater than the mean perimeter derived diameter of the annulus, more or less 10%. You're going to size, once again, based on the minimal dimension, the annulus. And at last, it's only in what we think is the most common phenotype of bicuspid, the tapered configuration with a very small supraannular region. You're going to size based on the minimal dimension, that is the supraannular area, or commissural to commissural distance. But quite reassuringly, in close to 90% of the cases, we can size based on the annulus, and this is really important for bicuspid aortic valves, and it's quite reassuring. And but we have to understand what is the aspect of the supraannular region, just to be able to avoid complications. So so this is something that we've published last year. If you do the supraannular tracing at 4 millimeters above the annulus, and the mean perimeter derived diameter that you're going to get is closely related to the mean perimeter derived diameter of the device after implant. So this may be helpful in gray zone configurations. So this is our patients. Overall, as you can see, the annulus 27.7, the ICD larger than the annulus, so we're going to size based on the annulus. 27.7, it could be a 29 sapien 3, it could be maybe a 30 Navitor for Titan, or it could be an Evolut Pro Plus 34. The sinuses of Valsalva are quite large, and the supraannular tracing provides 26. It tells us that the device is going to reach 26 millimeters. So even if we put something that is 30 or something like that, at the end it's going to be 26. So we need to be sure that the leaflets of the device we're going to use are not going to be in a difficult configuration with flow perturbances, disturbances because of the lack of expansion. So we decided to use a 34 to get a Evolut Pro Plus to get a good sealing, and that 26 millimeter diameter is nicely going to match the diameter of the part of the device that houses the leaflets. So this seemed to be the perfect device for our patient. In terms of procedural considerations to end up with that talk, first thing is to start with a two-cusp view. We're dealing with a bicuspid patient, so we need to find a two-cusp view similar to the cusp overlap projection. This is a type 1 left to right bicuspid valve, so it's very easy, RAO caudal, to get that cusp overlap two-cusp view. What we learned from the Bavolut X registry, focusing on the self-expanding platform, predilation in the vast majority of the cases, repositioning, reshiftting and repositioning when necessary to achieve landing across the annulus but quite high, and post-dilatation in close to 2/3 of the patients. These are the key aspects of the procedure. So let's come back to our patient. So you can see that for this typical patient, the cusp overlap, the two-cusp view was RAO caudal 25, something like that. So this was acceptable procedure-wise for the comfort of the operators, and you can see how that view appeared in the angiographically. So what we systematically do is to do a balloon valvuloplasty. So you're going to see, if you focus now on the left loop, that clearly what we see in bicuspid aortic valves is that in type 1 left to right, the raphe is going to prevent any expansion of the device and the balloon towards the anterior part of the anatomy. So everything is going to be biased towards the posterior aspect of the anatomy. It's only if you work in the RAO caudal projection, a cusp overlap projection, that you're going to understand that. So definitely in a contemporary way, two-cusp view, RAO caudal for bicuspid aortic valves is mandatory. You start high, as usual. And something that I like to do is to, the same thing as for tricuspid aortic valves, to pace once we are getting to the third node and the final, the full expansion of the device. And to get that very high implant, I like to pull the wire, and you can see that you can continue to pace as long as you have contact of the wire with the mid wall. And something that is also recommended is to do that rotational angiography, or at least 2 orthogonal views, to understand what is the, if there is some potential stent optimization to be performed by post-dilatation. And this is really crucial for bicuspid aortic valves. And this is the final result for our patient with a high implant, no regurgitation, a perfect commissural alignment. And even in challenging bicuspid aortic valves, this is something that we can obtain. So to conclude, so what are the key messages about Tavi for bicuspid aortic valves? To keep it simple, CT scroll technique for every single bicuspid aortic valve patients, not only to measure the annulus, but to understand everything as an integrative approach of these complex patients. So the annulus sizing makes sense in 90% of the cases, but keep in mind that in 10 to 15, that the device will be smaller than the annulus, 10 to 15% on average. So don't go bigger and bigger and bigger. This is not going to work for bicuspid aortic valves. Predilate, minor axis of the annulus at baseline for safety, high implants, but remaining across the aortic annulus, and reposition the self-expanding platform if necessary. Assess the stent frame in 2 orthogonal views just to make sure that you don't require a stent optimization, and post-dilate if necessary. So thank you for your attention.
Thank you, Didier, for this concise and really to the point presentation. So we have good time for some questions, actually, and please, I invite also Mohamed for participating in the discussion. I think it's very nice what you showed. You call it the CT scrolling technique, yes, where you scroll up and down the calcified leaflets to see how the pattern of calcification is. I have to say, it's something I do now the last 2 years also, even for every case, also tricuspid cases, just to really understand very nice how is that pattern of calcification. Is it symmetrical, not symmetrical, very bulky calcifications or not? I think it's indeed a very important aspect. How do you take that into account? Like, is it influencing a lot for your sizing if you have a very calcified raphe or not? Is that influencing a lot your sizing or not?
So that's really one of the key aspects of understanding the anatomy of a bicuspid aortic valve. Is there a raphe, yes or no? It is extremely calcified, and the extent, the length of the raphe. Sometimes you have a raphe which is calcified 50%, let's say, and this may not have the same impact as a fully 100% calcified raphe. As you saw, it's always the same thing. If it's a true bicuspid aortic valve type 1 left-right, the device is not going to move towards the anterior portion of the anatomy. Everything is going to go posteriorly. So if we put, for instance, a device that is balloon expandable and is quite large, I would modify slightly my technique and use a progressive inflation, two-step inflation, just to understand if there is room enough in the posterior aspect of the anatomy to go for a full inflation. So it's really important, and I guess this is, you are right to really stress that message. The CT scroll technique is really important. The location of the raphe, the calcium at the raphe impacts the device selection, impacts the valve size selection, and impacts the technique that we're going to use. So it's definitely different as compared to tricuspid.
Yeah, very good. I mean, Mohamed, what's your routine here in bicuspids? I don't know. Of course, bicuspids it's a terminology that covers a lot of bicuspids. Let's focus, for example, on the one we encounter most. It's a type 1 right-left fusion. What's your algorithm there to do sizing or also implantation technique? Where do you aim for the implantation, and what do you do for the sizing?
I mean, we do very similar to what Didier showed for the sizing. So we look, of course, at the annulus. This is important, not to forget it. And then we look at the supraannular level as well and see how does it look like. And I agree with Didier that in 90% of cases, you will end up by sizing to the annulus. But I think that looking at the distribution of calcification, as also mentioned, is important in valve type selection as well. Maybe even a little bit more important if you're taking a balloon expandable valve because of the risks you have if you're oversized. Because this calcium, I mean, it will need to give way somehow. And if there's no room for it, then this is why I think it's important to try and imagine what the valve is going to do with the anatomy. Is there room? Is there space to the calcium to a little bit deflect or accommodate the device with its size, or is there no room? Because if you don't have room, then you have problems.
Yeah.
Regarding
an implantation, where do you aim for your implantation? Do you aim the same as for your tricuspid implantations, or?
I mean, we want to implant high. And what our experience is in bicuspids is that you may get fooled up a little bit with your position. And if you have very long leaflets, very calcified leaflets, these leaflets tend to push your device downwards towards the ventricle. And this is why I think it's particularly important in bicuspids to aim at a high implantation, maybe even a bit higher than you would usually do, just to have a little bit of a backup plan just in case your valve gets down a little bit during implantation because of these bulky leaflets.
Yeah, it's true that if I may add just a bit on that, if we're dealing with a self-expanding platform, I would say that aiming at 0 or 1 to 3 millimeters below the annulus is good. For a balloon expandable platform, I tend to use the radiolucent line and to put it really at the annulus or slightly above to get a very high implant. So I don't really rely on the markers that tend to move during the tracking, and that radiolucent line is really efficient. If for the self-expanding platform, we should reposition, reshift when necessary, just to get there. Ole, just maybe you have a lot of experience. Do you utilize cerebral protection devices?
Yes, we do. Yes, we do. I mean, we routinely kind of use it, but let's say for sure, I would say in bicuspids and valve cases, that's for sure cases where I would really love to use cerebral embolic protection. And also we don't have to forget, I mean, bicuspids, it's, let's say in octogenarians, we saw it in less than 5% of our population, but now that we start to treat also patients from around 70 years, you see this 1 out of 5 patients, or almost sometimes 20-25% of your cases are bicuspid. So in these younger patients, you don't want to expose them to the risk of a stroke. Yes. But we have very limited time. We have a lot of questions still from the audience too. I'm afraid we won't be able to tackle them all, but maybe let's do them quick, like sizing in type 0 bicuspid. Do you follow the same rationale as you've been explaining, as you've done here?
So to keep it simple, yes, apply the same thing for everything. All the literature relates to type 0 and type 1 bicuspid. The only phenotype for which we don't have a lot of data are type 2. Type 0, type 1 behaves the same. In terms of circularity, it all depends on the calcium.
Yeah. And then there's a good question about any data regarding the durability of Tavian patients with bicuspid, or is there any concern from you, or what are important aspects to take into account when thinking of durability and Tavian bicuspid anatomy?
So we don't have full data on durability. What we know is that there have been some signals of halt and harm. You are a specialist of that in bicuspid aortic valve. So I do believe that it's when we implant devices that are too large, they're not going to expand appropriately. This may limit the leaflet movement. So that's why going bigger and bigger doesn't make sense for bicuspid. Use the right size. Sometimes when you are in the gray zone, the smaller device is going to do the job, be more circular and appropriate area to move, freedom of motion for the leaflets.
Yeah, but also what you stressed upon is that if you do the implant, you look to the valve from different angles and see if there's a lot of compression, under expansion of the frame, and that could also be a predictor of maybe under expansion of the stent frame, maybe more risk of health or leaflet thrombosis, etc., and less durability. But of course, that's a lot of speculation still. We need the real studies on this, but that's only interesting. I think we're right on time to go to the next topic. Unfortunately, we really, in the sake of time, we have to respect our timing. So Mohamed, I would like to invite you to give your presentation on valve-in-valve, Tavi, and all the complexities that are related with this.
Yeah, thank you, Ole. So I don't think I will be able to cover all complexities. So we'll focus a little bit on some of these. But I think it's important. I think it's important to remember here that the number and the percentage of valve-in-valve procedures are growing. So we are faced more and more with patients with degenerated surgical, and I think in the future also with failed transcatheter valves. And it's definitely, in my opinion, it's another animal. So I don't know why I cannot advance the slide. So maybe we go to the next slide. Yes. So it's definitely another animal. It's not like treating a native pathology, and it's definitely also, I mean, we treated today by chance 3 different patients with valve-in-valve, 3 in a row, and they were all very different. They are different surgical valves, they're different pathologies, the surroundings are different, and sometimes also the valve you're implanting is different. And I think this is why we should consider this a different animal because of this complex interplay of different valve designs. Next slide, please. So the main concerns with aortic valve-in-valve that relate to this interplay of surgical transcatheter valve and native anatomy are listed here on this slide. So we have concerns of higher gradients, we have concerns concerning coronary obstruction, and we have some concerns related to valve function and durability. Next slide, please. And one further concern, if you may wish so, is that we need also to consider future plans. The younger these patients are, and the more longevity we expect, the more plans we will need, considering what or the number of valve in valve we can perform in such patients. So to focus a little bit on one of these concerns, I'll be talking about coronary obstruction after valve in valve, because this, although it's fortunately not common, but it's still, the incidence is higher after valve in valve, particularly with certain surgical bioprotheses. You can see on this slide, we have concerns with the protheses that are externally, where the leaflets are externally mounted. We have some concerns with stentless valves. Fortunately, we can anticipate these issues or these problems quite nicely and in a very standardized way nowadays, and we shouldn't be facing or shouldn't be surprised by the occurrence of a coronary obstruction during a procedure anymore. There are a list of mechanisms that cause coronary obstruction, but if we consider the two most important mechanisms, please click Didier. These are the two seen on this slide, what we call deficient sinus and sequestered sinus. So we either cause direct coronary obstruction by deflecting the leaflets of the surgical valve towards a coronary ostium that is situated in the vicinity of these leaflets in a patient with a very small sinus or valsalva, or you have room in the sinus, but you have very long leaflets and you have a very, or combined with a more or less short length or height of the sinotubular junction, and then your leaflets, when they're deflected upwards, will sequester the sinus. So it's not a direct, but it's an indirect form of obstruction. There are some published classifications for that. You see here, for example, the Vivid classification, where you can classify the aortic roots into three different types, type 1, type 2, and type 3. And you can see here the ones marked in red. So type 2B, type 3B, and type 3C. These are more or less those where you have a risk of coronary obstruction because of the two mechanisms we just mentioned. We have also recently published what we think is a very useful algorithm, how to assess the risk of ostial obstruction or sinus sequestration, so the risk of these two mechanisms, based on pre-procedural CT measures, in order to stratify your patient into a patient that is at high risk, at low risk, or maybe at intermediate risk. And if you look here at what we suggest in this publication, the first thing we do, as Didier has shown for the bicuspid, we do this for all types of valves, and we definitely do this for assessing the risk of coronary obstruction as well. You just scroll up and down in an axial view and see if the leaflets extend above the coronaries. If they do not extend above the coronary ostia, then this patient would be at low risk. If they extend above the coronary ostia, then you need to do some measurements. The first measure you do is what we call the VTC. So you insert a circle or a virtual valve that has the diameter of the valve that you are expecting to implant. And if you have a VTC that is less than 3 millimeter based on the study, then you have a high risk. If it's higher than 3 millimeter, then you will go to the next step and try to assess the risk of sinus sequestration. So not the risk of direct obstruction, but the risk of sinus sequestration. And you need two measurements here. You need what we call the Stj height minus leaflet length. So it's simply a measurement of Stj height, and you subtract leaflet length. If it's less than 0, then definitely your leaflet is higher than the Stj height, and you will have a high risk. If it's between 0 and 1.9, it's intermediate. And if it's more than 2, you have low risk of obstruction. This should be combined with the VT-STJ, so the same we do for the VTC measurement, but at the STJ level. And if you have very small space, less than 1 millimeter, you are at high risk. If it's between 1 and 2.9, you are at intermediate. And if it's more than 3, you are at low risk of obstruction. So let's take this and show two case examples that are clinically very similar, but when it comes to these measurements, they are more or less very different. Case number 1, as you can see here, is a 70-year-old male, a trifecta valve, 25 millimeter, plus a bypass to the marginal branch, and he presented with stenosis. And you can see here that the height of the left and the right are at both very low. Case number 2 is a female, 82 years, also a trifecta valve, but a little bit smaller, 21 millimeter, has, by the way, the same graft to the posterolateral branch, has also a stenosis, and has also very low-lying coronary ostium. If we go to case number 1, we'll start with case number 1. Then let's try to apply this algorithm. Leaflets are both higher than the coronaries, so we start to measure the VTC. You can see here that the VTC for both coronaries was much larger than 3 millimeters, so 6.1 and 5.5. So at least according to this algorithm, there is no direct risk of coronary obstruction, but then we need to consider whether we have a risk of sinus sequestration. So we measure Stj height minus leaflet length, and you can see here that these are two positive values. So the leaflets are shorter than the Stj height. And if you measure the VT-Stj, it's bigger than 2 millimeter. You can see here on these images, it's much bigger than 2 millimeter. So despite low-lying coronaries in this patient, according to these measurements, has actually a low risk of coronary obstruction. And if you see what we did, we actually implanted an Evolut 26 without coronary protection, and the coronaries were fine. You can see here that there's a lot of room despite the low-lying ostium. If we go to case number 2, again, both leaflets are higher than the coronaries, and you can see here a very small VTC to the right. It's smaller than 3. So for the right, you're actually done. This right coronary artery is at high risk of obstruction. So let's focus on the left. For the left, you have what we call Stj Leaflet Mismatch. So the leaflets are a bit higher than the Stj, and the VT-Stj is very small. It's smaller than 1 millimeter. So again, for the left coronary artery, you have also a high risk of coronary obstruction by a different mechanism, by sinus of sequestration. So in this case, you have to do something. You can't just implant your TAVR device. And the methods we have the chimney or snorkel stenting. You pre-park a wire and a stent in the coronary artery that is at risk, and then you implant the device, and afterwards you pull the stents up and implant them higher than the Stj or higher than the surgical valve leaflet in order to maintain flow. This is one principle, and it's more or less commonly applied, and it's not that difficult to be performed. However, there are some disadvantages for this technique. We're not addressing the pathology. There is some unknown risks of restenosis and thrombosis, and reaccess, and this is very important, could be difficult to impossible. So there is the other technique, what we call leaflet modification, for example, using the basilica technique, which is by using an electrified guide wire. You puncture the leaflet, you snare the wire, you build a loop, and then again by electrifying this wire, you slice the leaflet, and so the leaflet opens up when it's deflected towards the coronary ostium, and this would maintain coronary flow. You can see here, for example, on the CT image that it works. So you can see here the sliced leaflet in front of the left and right coronary artery. In this case, you don't see it every time you do a CT, but this is a particular example where it was very obvious. We also have some anecdotal evidence. So this is a case, again, from our center, where it allowed also reaccess. So imagine in a case where you have complete sinus sequestration, even if you implant a stent beside the long core valve or Evolut device, it will be particularly difficult to re-engage between the core valve and the aortic wall if you want to do a coronary angiogram or a PCI, such in this case. In this particular case, we think that the basilica that was done 1 year before this coronary procedure helped us to re-engage. So this is what we did to the case number 2. So we thought both coronaries are at risk. So this patient was treated by a double basilica, as you can see here, followed by implantation of a self-expanding device with maintenance of coronary flow. Of course, this is a complex procedure. And if you go to the next slide, you can see here that even in a center with a very high volume, such as in Leipzig, we did over a almost 4-year period around 50 patients. If you need to do this procedure, of course, you need some experience, you need a case load, a case volume in order to achieve results that are reproducible. So I think it's important here to stress that you don't need to do this if you don't face this very frequently, but it's important to be able to identify patients that are going to need a procedure such like that, and it's not a shame at all to refer to a center with a bigger experience. Nevertheless, and this would be my final slide, there are some devices coming up that will facilitate these leaflet modification procedures and make these easier, more rapid to learn, and more fast to apply. This is one device which is called the shortcut device, which is a dedicated device that is currently being tested in a clinical trial. And I'm sure, because I think the need or the necessity for performing leaflet modification may increase in the future, that we're going to need dedicated devices in order for such a leaflet modification procedure to be applicable in a broad number of centers. And thank you very much for your attention.
Thank you, Mohamed. Very nice overview, and also touching upon the most critical aspects when doing valve-in-valve, Tavi. I think indeed it's true what you emphasized there. I think it's mostly important to recognize the risk of coronary obstruction and how you tackle this. That's typically the result of a long discussion, even internally in your group. Some will favor just putting on guide wire a coronary stent preventively. Others will go for the basilica. And indeed, I mean, you need your volume. I think you should, if you recognize the risk here, you should refer to a center which has experience on that. A question for me to you is, does the age of a patient also has an influence? Because I can imagine if you do a snorkel stenting or chimney stenting in a, let's say, 72-year-old patient, is it easy afterwards to go into that coronary again?
Yeah, I think age is a consideration, but also the presence or absence of coronary artery disease, I think, is important. Because even in older patients, if these patients already have coronary artery disease, and a lot have, then you need to gain access to the coronaries afterwards. I mean, the case example I've showed was actually an old lady in the mid-80s, and she required an intervention 1 year after the basilica procedure because of an acute coronary syndrome. So I think the combination of these two factors, age, but also the presence or absence of coronary artery disease, would be important if you are considering chimney stenting, and not only the age.
Yeah. And also a question is that I see, does one exclude the other? So are there sometimes cases where you do combined, so you do basilica, but still you put preventively a stent ready on a wire in the LAD, for example? You do this or not?
Yes, there are some. I mean, there are few these cases, and probably these cases are where you really don't have any room in the sinus, for example. So all measurements are 0 or 1. With very low-lying coronaries, where you think that even after doing basilica, there could be another source of obstruction, for example, by the new THV. And in these cases, we tend to protect. But what I would prefer to do, if no direct coronary obstruction occurred and you're not forced to do the chimney, that you try to engage through the sliced leaflet and then implant the stent orthotopically. If you have time to do this, probably this will have a benefit for maintaining access in the future.
And how do you assess that risk of cornea obstruction? Because if you have like a wire in there, do you sometimes use IVUS, for example, to see how much space there is, or you've never done this, or what's your experience on this?
Yeah, I mean, I personally never did IVUS, but I'm aware of some groups that are doing IVUS and trying to look at the footprints of the leaflets, if they are encroaching on the ostium or not. And I think there is one prospective study that is going to be planned, or is planned and going to be performed in order to assess the role of IVUS in this. But I more or less rely on the clinical assessment and the angiographic one.
Yeah. Didier, what has been your biggest lesson learned ever doing if you have to say 1 or 2 points when performing valve-in-valve Tavi, what are your lessons learned in your big experience over the many years?
Yeah, so I think that it's quite important to keep in mind that there are two main objectives for your patient. First, ensuring that you have a NEOA that is large enough with a minimal risk of mismatch for your patient. So fracturing the bioprosthesis or post-adaptation has to be part of the procedure. And the second issue to really anticipate is coronary obstruction. And sometimes both goals are in conflict. So it's really nice to have these techniques as the Basilica and hopefully in the future the shortcut devices, just to be able to combine everything and to get the best. So the hemodynamics is one thing, but the coronary obstruction is really immediately a dreadful complication for the patient. So we have to integrate, once again, an integrative approach, and this is contemporary, modern, and mature Tavi.
That's a very great point, I think, because indeed it's very often a balance. Yes, I mean, if you want to do fracturing because you're afraid of a high gradient, you endanger more your coronaries, and so it's not that straightforward. That's why it's complex. Yes, these cases very often, and I think Mohamed gave us a very nice glimpse into this, and I'm sure we can dedicate a whole webinar on valve-in-valve if we really want to go into detail there. I think we're really perfect in time right now to go to the last session. And that's a session I will try to take over control of the slides. That's about complex situations where you have difficulties with your transfemoral access. And here in this particular slide, you see that actually from the start of Tavi in the beginning, of course, there it was already the transfemoral retrograde approach, as we know now as our standard approach, was already used. But also in the beginning, there was quite a lot of use of transapical. That was, of course, due to the Edwards system, transapical use. Then you see over the last couple of years, so more surgically assisted approaches with surgically assisted transsubclavian, direct aortic, also transcarotid. But you see over the last, especially I would say 3-4 years, a more and more tendency to go really percutaneous. And then percutaneous transaxillary is one important approach there. And it's now also in the US, as I understood, the second approach after transfemoral. There is even the transcaval approach possibility, and also in the last 2 years, the shockwave-assisted transfemoral Tavi approach. So more and more tendency to go percutaneous, and that's also what we've been doing in Copenhagen, where I'm working in the center. So we're going there for a fully percutaneous program. So as you see, 90 to 94% typically, I would say nowadays, with the lower risk patients we're also treating, goes classical transfemoral. We can push these boundaries of the transfemoral approach really to 95, 96%, I would say, with PTA or intravascular lithotripsy-assisted transfemoral approach. And then these last 4-5% of patients, we have really difficulties going transfemoral. I think our first approach there is going percutaneous transaxillary, and in very few cases, we go transcaval. So that's our algorithm. As I said, these percentages, they fluctuate a bit, and the more lower risk patients and younger patients you treat, the less need you will need for alternative access. So in many centers nowadays, treating already lower and younger patients, you only need it for typically around 4% of your cases where you need some alternative. This is a setup that we have been using also to try to keep as much as possible cases transfemoral. So I would say keep calm and stay transfemoral in the majority of your cases, even very calcified cases, as you see here. So they can be 360 degrees calcified with intraluminal diameters of as low as 3.5 millimeters. If it's not completely circumferentially 270 degrees calcium, we can even go accepting intraluminal diameter cases with 3 millimeters. Of course, it's also depending on how diffusely this iliofemoral access vessel is diseased, but it is definitely shown its use in many cases. I want to go, however, in more detail here on percutaneous transaxillary Tavi. So this is a case example of how we perform this percutaneous transaxillary in a safe and effective way. So this is a case with an annulus of around 88.5 millimeters perimeter. A similar measurement in the LVOT, so a larger anatomy. We see in the SOV that this has dimensions of 34 by 35. The ST junction is pretty good calcified, is not that large, so the aortic root is not extremely large here. The coronary heights are acceptably good. And then, as you see, we already also do this for every case. We scroll up and down these leaflets, as you see in the small video on the left-hand side. So what is important for me there is to assess the amount of calcification, how symmetrical this calcification pattern is, etc. So I really do this. I don't like to trust only on that still-framed hockey puck view, as you see on the right. I really like to scroll a couple of times through these leaflets, as Didier was nicely showing for the bicuspid. And then here, what is of course also important, if you consider percutaneous transaxillary or especially transaxillary or subclavian or also transcarotid, is to really look how angulated this aorta is. If you have to tackle a Tavi case in a very horizontal aorta, it might become rather complex coming from the carotid or the subclavian axis. So it's really important to look at this pre-procedurally. And here you see that's the reason why we turned this case down for transfemoral. You see on the right-hand side there is actually virtually no access, or it's a subocclusion. On the left-hand side it's severely calcified with only 3.2 millimeter or 2.2 millimeter, even with chunk of calcification. So this is not a case you can do transfemorally. I would say we push the boundaries transfemorally really much, but a combination of severe calcification and tortuosity is a no-go for us. Also, if there's if there are stents in the iliac or in the femoral artery, that's also typically a no-go. And also, if there is severe disease of both iliacs or the iliac bifurcation, if that's involved, it's also a more tricky situation. So clearly, this case was not good for transfemoral access. So we had a look on the subclavian and axillary artery. And as you see, this looks very nice. We have diameters of above 6 millimeter with only mild calcification. Don't be afraid of that tortuosity you see there in that axillary artery. That's just because the patients are laying with their arms up under the CT. That's not because it's very tortuous. And so this case was accepted for percutaneous transaxillary Tavi. How do we perform this step by step? We make, first, we prefer, of course, the left transaxillary axis, not the right, because then there's still some more space to push your valve to the outer curvature in the aorta. If you go from the left, there's more length to play with the shaft of your delivery system. So we start with going in with the 6 French arterial sheet. We place a pigtail, or nowadays I do it more with a multi-purpose because the pigtail distorts a little bit the artery. So I go with a multi-purpose catheter, and then we do a combined echo fluoro-guided puncture, as you can see here. So this is the multi-purpose that comes up from the radial artery, and typically the zone where I want to puncture my axillary artery is in between the rib cage and the medial side of the humerus head. That's the zone where I want to do my puncture site, where I want to do my puncture and have my puncture site. So that's also what you see here. So this is the puncture, and we nicely go in. Then afterwards, of course, we just use 2 ProGlides or Pro styles. And after these 2 ProGlides, we just place our 8 French sheet. It's important you don't go for a bigger sheet yet, because you want to have some space still to come with your safety wire from the radial axis. And then afterwards, when the safety wire is just placed in the abdominal aorta, floating in the abdominal aorta around the level of the renal arteries, for example, that's typically a 0018 wire. I like to use a platinum wire for this because it has a floppy end and it has still enough stiffness in the body of the wire. And after this 8 French sheet placement, I typically already go crossing the aortic valve. I don't upsize already for the bigger sheet, so I reduce the ischemia time in the arm of the patient. So that's what you see here. This is for the placement of the ProGlides. Be careful, I would say. This is really important that you pull back that catheter that you have laying there in that axillary artery before you shoot the needles of your ProGlide. Otherwise, you may shoot your needles through this catheter, and that could be a big complication. So before you do that, make sure there's no catheter. And also it's important for placing the safety wire, only do this after you've placed the proglides and your 8 French sheet, and otherwise you may risk that your safety wire gets caught by the proglide. So also that is important. So all these steps are not very complicated, but it's just you have to respect the sequence of these steps. So this is after the 8 French sheet has been placed. We place the platinum wire from the radial axis, and we go into the abdominal into the abdominal descending aorta. And then we start crossing. We typically like to use a sentinel device here. If you can't, because there's really no access from the transfemoral axis, if they're both completely occluded, of course you have to go, you have to use the right radial artery for your pigtail placement. But in this particular case, we could still go just through the left iliofemoral artery, and then we prefer still to use this cerebral embolic protection. Then we place our stiff guide wire, and only after this, we change our 8 French sheet with a 14 French sheet, just to go in and out with this 14 French sheet, and then somebody compresses shortly, and you go in with your delivery system of your evolute valve, for example, with your integrated sheet. And then you do your implantation. So I have some images here. We did a pre-dilatation in this particular case, 24 millimeter true balloon, because remember, it was a large anatomy. Then we come with the valve. That should come here. Yeah. So this is also a right-left cusp overlap view. We do the implantation here and expansion with some pacing. And then we do the release. And this is already afterwards. What I would like to say is, what is different if you do, I'll go back to the previous slides maybe. After you've just placed your valve, it's important that you recapture your nose cone while your nose cone is still in the ascending aorta. So this is something different than when performing transfemoral Tavi. So as soon as the valve has been deployed and released from the delivery catheter, I typically bring in the nose cone into my stent frame, and already there I start bringing my nose cone back to my delivery system so it's closed, and then you can take out your delivery system and bring in your 14 French sheet again to close the puncture sites and have no bleeding there. So afterwards we did a control then, and that looked, we were satisfied with this result. And then the closure, of course, that's maybe the most important step, how we do this closure of a percutaneous transaxillary case. Well, we always use 2 proglides there. We use also always an anguicil in the middle, and I always use a balloon coming from on my platinum wire from the radial. And why do I do this? Because it optimizes, first of all, the anchor of the anguicil to press into the vessel wall, but also you have more time and more chance to get really the knot of the proglide pushed to the vessel wall. This is not always possible if you do not use a balloon, because you don't have that posterior resistance here in your axillary artery as you have in your femoral artery. So in order to create some resistance on this artery, we inflate just a 7 or 8 millimeter balloon. You have all the time, just at the spot of the puncture site, you push nice your knots, where you push knot pusher to the vessel wall, and then afterwards we make a final. So that's what you see here. This is that pusher of that small anguicil, which you see. This is the platinum wire with the balloon, and then we inflate. We're pushing extra on the knots, and afterwards. In 95% of cases, we had always this kind of result. Only in 3 out of 50 cases, we had to use a covered stent. And that's also rather easy to do. You have your safety wire still in place then typically. Here, my colleague had already pulled it back, but typically we prefer to keep our safety wire here. And then you can just exchange this very rapidly to a Amplat super stiff wire and bring in a covered stent and place it if you really have to seal it. So I would say, what is our experience with this percutaneous transaxillary? Well, very good. I think we compared the last 40 surgical-assisted transsubclavian cases with our first 40 percutaneous transaxillary cases. And as you see, major vascular complications, it was not rare with surgically assisted transsubclavian access. We didn't see any with percutaneous transaxillary. Also, rehospitalization rate are lower. Why is this? Well, you can see that what are the complications we saw in these surgically assisted. First of all, unplanned endovascular intervention still needed in 2 cases with, of course, major bleeding. Also, permanent access site-related nerve injury. We never saw this after percutaneous approach. And also, what brought these patients back after surgically assisted transsubclavian access? Why did they get rehospitalized? Well, first of all, increased hematoma. Also, it's still a surgical wound you make there, so fever and increased infection parameters, in which in local hospitals there was even started antibiotic therapy for it. We don't see this after the percutaneous and really minimal invasive approach. Also, persistent pain and reduced grip force in the left arm was also seen after this surgically assisted access. So we prefer nowadays this percutaneous transaxillary approach, and this as a part of our fully percutaneous TAVR program. So I would say, Mohamed and Didier, we have come almost to the end of this webinar. We've touched upon different complexities when doing TAVI. We have had the bicuspid, the valve-in-valve, or the alternative access. Maybe some final key message that you want to communicate on the session or on your particular topic?
So if I may start, I have to say that I learned a lot from you guys. So thank you for sharing your experience. And it's really nice. It's always very important just to share our experience. And we all have our techniques, our feelings, deep feelings, but sometimes it's good to confront those to the experiences from the other ones. And I learned a lot from you guys. And it's going to improve my practice when it comes to valve-in-valve for sure. And when I was listening to you all, I was really thinking that I was going to try that percutaneous transaxillary procedure the next time I face some difficulty in the femoral artery. So we are always improving our knowledge, and thank you for sharing yours. And I hope that the audience also got that, and particularly for bicuspid aortic valves, which was my topic.
Yes, great. A moment, maybe some final words of you before I go over the key learning points and then finalize the session.
Yeah, I agree with Didier. Of course, it's very fruitful also to see how you guys are doing your procedures, how Didier is doing his measurements and his tips and tricks for bicuspid, and how you are doing the transaxillary, because I think there are some nuances that are maybe a little bit different from one center to the other, but it's really helpful to see these slight differences and try to learn and adjust. Even if you're a high volume operator or you did several hundred procedures, you still have room for learning and improvement. We don't have time, for example, now to discuss why you're not externalizing the wire in transaxillary, because we still do this. We'll do this maybe separately offline, but I think these are things that are very important nowadays, that we learn from each other and try to improve and adjust our practice. So thank you both for that. It was very fruitful for me as well.
No, I fully agree, Mohamed. And yeah, it's these small finesses to make your practice even really better, and especially also safer. Typically, it's a lot to prevent then these complications, and that's what we really want to obtain for our patients as well. Yes. So let's bring up the final slides, I would say, to go through some key learning points here that we hope we obtained. So Didier, he discussed Tavi and bicuspid aortic stenosis. I think for me, what was really interesting is to see his CT scrolling technique, as he calls it, and I really like that. I think this is really key for sizing in bicuspid, but also I would say indeed in tricuspid, please do it. You learn so much before you engage yourself in that case. I think especially in bicuspid, it's key for sizing with an integrative approach. And as Didier also came to say, 90% is still annular sizing, but still it's important to understand that full anatomy of that bicuspid valve. Also a step-by-step approach, as Didier was touching upon. I think do this careful. I mean, if you treat a bicuspid valve, Didier told us to do a pre-dilatation in most of the cases, matched to the minimum diameter of the annulus. Go for a high implant typically, and then do a post-dilatation if it's really needed. If you see some stent frame constrainment, probably it's good for durability for the gradients of this particular case. So a very nice step-by-step tackling of this case is important. Valve-in-valve Tavi by Mohamed. What I learned this year, it's important really to do that risk assessment of coronary obstruction. It's really key when you engage yourself in such a case. And knowledge is needed of possible techniques. We don't say you have to be able to do all this yourself, but you have to know what is available. Snorkel, chimney stenting, basilica, these techniques have to be known terminologies. And if you think your patient needs this, either you have to learn it, you have to bring a proctor in, or you have to refer this. And then finally, Tavian case with difficult transfemoral access. Well, IVL or intravascular lithotripsy-assisted transfemoral TAVI should be considered as a first option to push your boundaries, but percutaneous transaxillary TAVI can be adopted as a safe and effective alternative approach. Use of a safety wire should be standard there. But I think altogether, I would say pre-procedural planning here is really key for TAVI success. So this brings us to the end of today's PCR webinar. I hope really that you found it informative and to have met its educational objectives. I would also like to thank again our faculty, Mohamed and Didier. Really thanks a lot for your contributions here. They were really great. And our thanks for joining us today, and goodbye.
Bye, guys.